I will.
But you don't have to let all the others in.
But now I don't see the option to let, I don't have all that.
Yeah.
Great. So I'd like to turn our attention now to today's topic and our speakers. As you notice from the title of the talk, it's on human motor control and neuromodulation. And in case you're wondering what neuromodulation is, it's the process of modulating brain activity by delivering electricity directly to the targeted area. So I'm sure you all are familiar with deep brain stimulation, because that's a common topic with PD, people with Parkinson's. And so neuromodulation is deep brain stimulation is a form of neuromodulation. So the focus on the talk is going to be the research being done at the lab of Dr. Helen Bronte-Stewart. And we're going to talk a little bit about one of their existing ongoing trials called the SPRING trial. And Dr. Bronte-Stewart is a professor of neurology at Stanford University, also a movement disorder specialist. She's the principal investigator of the Human Motor Control and Neuromodulation Lab, where she performed the first closed loop deep brain stimulation study for gait impairment and freezing of gait in Parkinson's. And that will be the kind of the primary focus of this talk. Essentially, her team is studying the neural code that's responsible for gait improvement and freezing in Parkinson's. And they're trying to reverse engineer the brain circuitry to restore movement for people with Parkinson's. They are doing this use what's called a closed loop. So it's a demand-based system. So unlike current DBS, which is sort of a closed loop and it only receives input from outside, from external stimulation, they're looking at using DBS in what's called a closed loop, where you're allowed to have inputs also from your own movements and from the circuitry in the brain itself. So it's a really novel way to use DBS technology. So today's speakers are Jillian Melbourne and Amelia Lambert, both research assistants from Dr. Bronte-Stewart's lab. They both have bachelor's degrees in neuroscience. Jillian's interest in Parkinson's stems from her research at the UCLA Movement Disorders Clinic, where she was one of 10 studies nationwide to participate in an internship with the American Academy of Neurology. At Stanford, Jillian is interested in combining quantitative and qualitative metrics to study Parkinson's. And Amelia, her previous experience was at a sleep clinic and also as an intern at a biotech startup, focusing on digital biomarker technology. At Stanford, she's exploring the biomarkers of Parkinson's to better understand the electrophysiology of Parkinson's. Jillian and Amelia will give a brief overview of the closed loop or adaptive DBS and highlight one of their ongoing trials, which specifically looks at how current DBS can be improved by allowing input from the brain and from motor sensors. So as a reminder, the purpose of the roundtable is not to provide clinical advice, and the presenters are not able to answer any clinical questions. All clinical questions should be directed to your healthcare providers. So with that, I'm going to turn it over now to Jillian and Amelia.
Thank you, Monique, for such a warm introduction. I think Amelia is going to work on pulling up the PowerPoint. And she's excited.
Uh-oh. Okay, hold on one second. I muted everybody and I muted you guys too.
No, it's okay. I've unmuted myself.
Okay, thank you. Sorry about that.
No, you're fine. So as Monique already mentioned, we're members of Dr. Helen Bronte-Stewart's Human Motor Control and Neuromodulation Laboratory at Stanford University. And we're here today to discuss our prior research and one of our ongoing clinical trials.
So before we get started about what we do in Parkinson's disease research, we kind of wanted to give you a broader look at the areas that are involved in research right now. So there's three main types of research that are going on in Parkinson's disease. There's the clinical research side. So this is the development and study of therapeutic approaches to Parkinson's disease. And this is really where our lab is focused. We're looking at neuromodulation for Parkinson's disease. So it would really fall into this category of a therapeutic approach to Parkinson's disease. But there's also translational research. So this is tools and resources that help move the novel therapeutics from basic research into clinical practice. And then there's basic research, which is more of a bench-based research that's focused on scientific discovery. So looking at those cells that are related to Parkinson's disease and doing that kind of research with novel therapeutics.
So as Monique kind of already mentioned, our lab is interested in novel algorithms and technologies for diagnosis, quantitative symptom evaluation, and neuromodulation, specifically DBS in Parkinson's disease. The NINDS-PD conference cited axial motor symptoms such as freezing of gait and gait impairment as the highest priority category for research in 2014. More than 10 million people have PD, and of those 10 million, 54 to 75% have gait impairment and or freezing of gait in cross-sectional studies. Resultantly, work surrounding freezing of gait and gait impairment has become central to Parkinson's research. DBS has been a standard of clinical care in Parkinson's research for the past 25 years. However, finding the correct level of stimulation requires physicians to use unreliable qualitative scales and can be like trying to hit a moving target. Our lab is interested in quantitative metrics to optimize lead placement and stimulation frequency, intensity, and directionality. The SPRING study uses quantitative biomarkers recorded from brain signals and or body movements to optimize stimulation in real time.
So another broader overview slide is about what deep brain stimulation therapy is. So it's one of the clinically approved therapies for Parkinson's disease. And the current system looks like an IPG, or an internal pulse generator, that's implanted in your chest, which is connected by extensions to leads that are placed in targets that are known to alleviate disease symptoms. So at Stanford, we use a target called the subthalamic nucleus, and that's where the leads are placed in order to get both information about sensing and then also about delivering the current that is known to alleviate disease symptoms.
So as I mentioned earlier, a major focus of our lab's research is gait dysfunction and impairment in movement disorders like Parkinson's disease. One of our specific focuses in Parkinson's disease is freezing of gait. Here you see an example of a person with Parkinson's disease experiencing a freezing episode while turning. This symptom is known to not be well controlled by optimal medication therapy, such as a combination of dopaminergic medications and DBS. Our research is exploring whether another therapy or another kind of DBS therapy in Parkinson's disease could be a better therapy for freezing of gait.
So on this slide, we're going to go over a little bit of previous research that has led us to what we are doing now currently in the lab. So one of our tasks that we do in research is this stepping in place task that you'll see here in a video that I'll show you. So it was the first metric of freezing of gait that we were able to identify that correlated with a self-reported freezing of gait scale. So you can see on the right side of this screen that there's a stepping in place task trace. So it's on two dual force plates that you can see in this little example picture. And it's normalizing your body weight so that when one foot is down on the plate, you should see that larger, or you should see a null, and then, or where it's at 50%. And then when the other foot is up, you should see it at 100. So a normal walking without any gait impairment or freezing of gait, you would expect to see this normal oscillation of the two different sides of the force plates. But then if you have freezing of gait, you will see that it looks a little different, where you see these episodes where there's not as much of the oscillation. So what we were able to find is that in this task, you see a correlation between the freezing of gait scale, where a person who had no freezing of gait had this trace. A person who froze rarely had this trace, the second one down. A person who froze often had the third trace down, and the person who froze always when walking had the fourth trace down. So this was really allowing us to be able to see in clinic and in our research setting what freezing of gait looks like to a quantitative measure, because it can be kind of difficult to describe this sensation and to have it occur during clinic when a physician or a researcher can watch you.
As Amelia kind of alluded to, one of the difficulties of freezing of gait is that it's quite difficult for clinicians to see, as people often experience it in their home environments. One of our graduate students who recently got her PhD, Dr. Hannah O'Day, developed a task called the Turning and Barrier course. Up until this point, there was no reliable task that could elicit freezing during free walking in a clinical environment. But this course was designed to induce freezing behavior as a part of a free walking task. As you can see in figure B, the course is closed and purposefully limits sensory cueing that some people use to overcome freezing episodes. The course also creates environments frequently that elicit freezing behavior, like turning and simulated doorways in the center of the course. Our lab found that people who freeze, as determined by the freezing and gait questionnaire, spent more time freezing in the course than non-freezers, and showed more freezing in the course than during free walking alone. And so this course is one of our metrics in the study that we use quite frequently to elicit freezing of gait.
So we're really interested in creating quantitative metrics for freezing of gait. So understanding how a sensor would look at freezing of gait is really interesting to us, because then we can use this input to drive a closed loop system for deep brain stimulation. So we have these tools that we use in our lab called inertial measurement units. It's similar to the device that's in your phone that allows it to track like your movement and do different measurements like this. And ours look like the one on the screen here. And using these sensors placed on people's ankles, we can actually see what a freeze would look like to one of these sensors. So in this video, you'll see a participant walking around the turning and barrier course. And when they get to the back of the course at the turn, you see a little bit of a freezing event, which is shown as a reduction in this measure called shank angular velocity.
Another technology that's enabling the advancement of neuromodulation is the sensing lead. So this is a zoomed in subthalamic nucleus, and it's showing kind of how this lead would go about sensing in a zoomed up. And you can also see the local field potentials, which is the recordings that these leads get. This lead allows the neurostimulator to receive neural signals called local field potentials, which is the green signal at the very bottom. These signals contain biomarkers that correlate with different symptoms of Parkinson's disease, which allows the neurostimulator to respond or control the stimulation in real time in response to symptoms.
And like we mentioned previously, this one thing that our lab did that was novel was the first implantation of a concurrent sensing and stimulating neurostimulator in the United States. So this was at Stanford in 2013. And we had the largest cohort in the world of 23 people with PD that were implanted, and we had 7 replacements, which means that we were able to study these people longitudinally. So we have a great wealth of data that we were able to then correlate with the symptoms of Parkinson's disease that couldn't have been well correlated before. We needed this sensing technology in order to be able to see what Parkinson's disease looked like to a freely moving individual with Parkinson's disease. And this really enabled us to do this so that we could have these relevant control variables for a closed loop system for deep brain stimulation.
These recordings allow us to see what the signals in the brain look like as they change during different behaviors like standing or walking. Here you see an example of what these brain signals or local field potentials that come from the sensing neurostimulator look like. So you'll see graphs that are called spectrograms that show the power of different frequencies of electrical signals in the brain that the sensing neurostimulator can detect. Red indicates a higher power, which we know is related to the pathological symptoms of Parkinson's disease. These signals are also impacted by movement, and here you see the difference in the recordings when someone is standing still versus when someone is walking. So we know that these signals are attenuated during movement. And so it makes a lot of sense to us that we see a lot more of that red while someone is standing in place as opposed to when they're walking. And the controller that we are designing for adaptive stimulation would be able to respond to differences in these signals.
So another experiment that we did in our lab was to see what does the sensing part of this look like when you have a freezing event? So what's going on in that area of the brain that we're able to record from while you're having one of these freezing events? And we found that during a freezing event, the pathological bursts that are related to Parkinson's disease in this band called the beta band were much longer than a normal burst where you were seeing normal gait. So you can see here in this top part of the figure, a shorter burst would look like these little oscillations, whereas a longer burst is occurring for a much longer period of time. And these longer bursts were correlated with the freezing events in that same stepping in place task that we showed you earlier that our lab uses as a tool.
So now that we've identified these signals, both in kinematics and in neural biomarkers, and we have ways of inducing freezing, the question becomes, what do we do with this information? As Monique kind of alluded to earlier, a really helpful comparison is the cardiac pacemaker. So cardiac pacemakers respond in what we call a closed loop system. They can sense the heart's electrical rhythms on demand and become activated when the heart rate goes below a threshold. This allows them to use adaptive and automated stimulation algorithms customized to the patient. Unlike cardiac pacemakers, modern deep brain stimulators are what we call an open loop system. This would be like a cardiac pacemaker that doesn't know the difference between someone who's walking or running or standing completely still. They can't sense or respond to the brain's electrical rhythm. Instead, the device constantly sends electrical pulses of a fixed frequency, amplitude, and pulse width. The Bronte-Stewart lab is looking to advance DBS neuromodulation technology so that it's up to the same standard as cardiac pacemakers. And we plan to do this by using the signals that we've found to drive algorithms that allow our pacemakers to respond to neural and kinematic signals.
So one of our experiments that we did before our current study was looking at whether this closed loop system in an embedded fashion, so if the device itself that's implanted in your chest has computational power, it can do some of these algorithms by itself without any extra equipment. So using one of these algorithms that was allowed for research in the last generation of the device, we were able to do experiments to see whether bradykinesia might be improved by this closed loop deep brain stimulation. So in the top part of this figure, you'll see what it looked like off stimulation for somebody performing a task that we do in our lab in our current study as well, called the repetitive wrist flexion extension task that kind of looks like what I'm doing with my wrist right now. And you can see off stimulation, this person was not able to perform the task. Then in the middle of the panel, you can see that the person was able to perform the task better, which is denoted by this change in a measure that we call arrhythmicity. So you see that their arrhythmicity goes from 121% to 24% arrhythmicity. And then you see in the bottom one that's hinting at maybe closed loop could be better for bradykinesia as a symptom, that there's this even more reduction of this arrhythmicity value when using this embedded closed loop system. Another advantage that we've seen in research to using this closed loop system is that it typically would deliver less power than an open loop adapter or an open loop system. So what does this mean in terms of advantage? It means that you probably have less battery being drained, so you would get your IPG replaced less frequently, which would be very nice.
This is the same experiment that Amelia was just talking about, except there's a video of it. So here you can see, I think, a trace of this person's hand as they're attempting the task, and you can see that they can barely perform it. And then here, this is the task of closed loop DBS. And you can see again that this metric that we call arrhythmicity, which we use for bradykinesia because the idea of bradykinesia is that you're slowing down and your movement is halting. And so your movements are ultimately becoming less rhythmic and less even against themselves. So the more rhythmic and the more the same your movements are, the less pathological we deem them. And it was proven that a fully embedded closed loop DBS was superior to clinical open loop for bradykinesia in this upper extremity task.
And then the last part of our previous research that we'll discuss is that there seems to also be some benefit to walking for this. So we showed you in the last two slides that there might be some benefit for an upper limb extremity task. In a paper published by a previous research engineer in our lab in 2020, they were able to show that for two individuals that there's this, you can see on this slide for two individuals that on one side for one individual on the left side, and then for another individual on the right side, that there's an improvement in the amount of freezing that they're experiencing during the stepping in place task when going between off stimulation on the top two panels, on open loop stimulation in the middle two panels, and then on closed loop stimulation on the bottom two panels. And the freezing events are denoted in these green lines here. So you see that same arrhythmicity that you see in an upper limb extremity task in this lower limb or in this bilateral task. And you can also see here as well that there's that same reduction in power that you would see with a closed loop system.
So go ahead.
Oh. So we're not currently enrolling for this study anymore, but it is ongoing in our lab. And this is the adaptive deep brain stimulation algorithm for personalized therapy in Parkinson's disease. And the purpose of this study is to determine the safety and effectiveness of adaptive deep brain stimulation for the treatment of Parkinson's disease. So it's ongoing in the United States, looking for approval for this therapy so that it can become clinically available to everybody. Right now, it's only available in select research studies because we're still trying to determine the safety and effectiveness of the study or of the therapy.
What's also worth noting about the adaptive PD study, though it is no longer enrolling, is that it is a pivotal clinical trial to determine whether ADBS is safe. And our lab is the principal site, which is pretty exceptional that Dr. Bronte-Stewart is leading that up because it is an international study.
And as part of this study, they're testing to see whether two different algorithms for this therapy are safe and tolerable for people that have Parkinson's disease. So there's a single threshold therapy, which means that anytime your pathological signal goes above a level that's set for you to be determined as something that's uncomfortable, that your stimulation would increase, so that you're only getting extra therapy when you need extra therapy, which is one of the benefits of an ADBS algorithm. And then there's another one that they're testing called a dual threshold model, where it has to go above a second upper threshold in order to receive that extra stimulation. And then if it goes below a lower threshold, then it would decrease the amount of stimulation that you're having, so that if you don't need more stimulation for your symptoms at that time, the device can make that modification and then you're using less power and it might be better for you in the long run. That's something we're still looking into.
So the study that we are currently recruiting for is called the Stanford Spring Study, which stands for Stanford Parkinson's Research in Neuromodulation for Gait. And if you can say that 5 times fast, I will be very impressed. The focus of this study is on how we're beginning to utilize closed loop DBS for treating gait impairment in Parkinson's disease.
So here you really see the culmination of all of the research that's gone on in our lab in the past 10 to 15 years. You can see that now we're able to create these closed loop systems that have two different methods, one using the brain signals from the sensing neurostimulator to make changes based on these burst durations that we've seen to be either non-pathological if it's a shorter one, or pathological to be a longer if it's a longer one, that you can make modifications based on that. And then the kinematic algorithm that's using the sensors placed on ankles in order to detect these freezing episodes to make changes to stimulation that we have seen to be potentially beneficial for people with Parkinson's disease during a freezing event. And both of these therapies, or both of these controllers, are testing different stimulation frequencies in order to see whether one of those two is better for people with Parkinson's disease. And it's really interesting too, because it's super individualized therapy. So you can see maybe one of these works better for you and another one doesn't. And it's very interesting to see that over the course of the study.
So with a closed loop neurostimulator, we can decode complex motor behaviors related to slow arrhythmic gait and correct abnormal brain activity by adjusting stimulation. The SPRING study is our first clinical investigation into the safety, feasibility, and efficacy of both neural and kinematic closed loop subthalamic nucleus DBS for gait impairment and freezing of gait.
And this is just our Institutional Review Board approved flyer for our study. So this is how we publicize our study to everybody, because our Stanford IRB, which makes sure that all of our research is ethical and okay, has approved this poster for us. And then the aims of our study, so what we're looking to see whether these are working, is the feasibility of a bilateral subthalamic nucleus neural adaptive deep brain stimulation algorithm that's driven by neural markers of gait impairment and freezing of gait, and using control policy algorithms that adapt deep brain stimulation intensity at two different frequencies. So that will be 140 Hertz and 60 Hertz frequencies for deep brain stimulation. The second aim is to see the feasibility of bilateral subthalamic nucleus kinematic adaptive deep brain stimulation, driven by behavioral markers of gait impairment and freezing of gait, and under control policy algorithms that adapt either the intensity of your stimulation or the frequency of your stimulation. And then the third aim is to test the safety and tolerability of adding subject-specific doses of dopaminergic medication during the use of these neural adaptive controllers, or the kinematic adaptive controller for gait impairment at freezing of gait or freezing of gait, using control policy algorithms that adapt either the DBS intensity or frequency. And that's really just the goal of these therapies. Aren't often used in isolation. So making sure that they're safe with a patient-specific dose of medication is really important, because if you only test them in isolation, you're not going to get that interaction that could potentially be there with medication. So making sure that that's safe as well is a really large goal of this study.
For the SPRING study, the inclusion and exclusion criteria largely correspond to the standard surgical criteria for DBS, plus a few additional criteria regarding gait. We aim to recruit participants who have gait impairment and or freezing of gait. And it's important to note that we can include people with gait impairment, but no freezing of gait, as they often convert over the course of the study, and we're studying how adaptive DBS improves gait impairment itself. Additionally, subjects cannot have significant amounts of tremor. They must meet the center's criteria for bilateral subthalamic nucleus DBS surgery for Parkinson's disease, and they must be able to walk unassisted and not present a high risk of falling while doing so, though the researchers are right there monitoring participants at all times. Some potential roadblocks to note include having Kaiser insurance, because participating in this study requires transferring your care to Stanford Neuroscience Health Center.
And then we'd like to end by reading you a comment from one of our research participants about how they felt on the adaptive deep brain stimulation controller. So the best analogy I thought of is like riding a bike riding a 10-speed bike up a long hill climb. Just as you start feeling some fatigue and slowing, the gears automatically shift. The result is that you feel less resistance and have newfound stamina and energy. As you continue, it shifts again, and it seems to do this in advance of the fatigue. It is an amazing sensation.
That was a quote from one of our participants who's a very prolific mountain biker. So we just wanted to thank you all for listening and for giving us your time. We really appreciate the opportunity to speak with you.
Thank you so much.
Thank you, Jillian and Amelia. That was wonderful.
Nice. And one more thing we wanted to note, we understand that deep brain surgery might not be of interest to you, but if you are still interested in participating in other studies at Stanford, there is the clinicaltrials.stanford.edu, which we can pop into the chat, which is where you can look at all the clinical trials that Stanford has ongoing right now, as well as this REDCap survey, which you can fill out, and then you'll be in the Stanford Research Registry where they can match you with research opportunities that are potentially a good fit for you.
Jillian, if you wouldn't mind copying and pasting those into the chat, that would be terrific.
Okay.
We'll also try to include some of these links that have been going out to folks in the chat in a follow-up email, so it'll all be there. And then, of course, as Monique mentioned, on our YouTube channel, you can review the whole presentation all over again.
Yeah, wonderful. Thanks for letting us know about those other opportunities. So just to clarify then, if you're interested in this research and would like to be in this study, do you already have to have DBS in, or is that actually part of the study, is having the DBS implanted?
That's a great question. So for this study, we're looking for people that have not yet been implanted with deep brain stimulation. So that it's not, our study makes a pretty clear delineation between clinical care and research, but it is, we work with your clinical team in order to get you implanted with the device that we use.
Okay, so you would have to be meeting sort of clinical recommendations for needing DBS.
Exactly.
Which I know that you can't give clinical advice, but I'm wondering can you speak a little bit about what that might look like? How might somebody be coming upon making that decision?
Yeah, so if we want to go back to the inclusion-exclusion criteria, I think what is most often the standard for what makes someone a good candidate for DBS surgery is if they're responsive to levodopa, and if they're experiencing that levodopa might not be working as well as it once was. But obviously, if you were to go through most hospitals, they would have a DBS review board where you would be seen by a group of neurologists and neurosurgeons who would decide whether or not an individual would be a good candidate for surgery.
Okay, that makes absolute sense. Thank you for clarifying that. So it sounds like the study that you're looking at is how you can use this closed system to improve gait. Is that system being explored for other symptoms of Parkinson's, for balance or sleep or anything like that, or in your lab?
It is. So one of our secondary outcomes is the qualitative scale that a lot of physicians use or providers use, called the UPDRS-3, which is Unified Parkinson's Disease Rating Scale. And that includes other metrics. We also have upper motor extremity tasks in the study, as well as speech tasks, which are all secondary outcomes to the primary outcome, which is people's gait. But it is essentially just making additional checks to make sure that everything is safe and tolerable.
And is the reason that you're really focusing on gait is because it has an easy quantitative measure? Like you have the wearable sensors and actually get that immediate feedback easily?
That's a really good question. So we are able to quantify other symptoms of Parkinson's. We have metrics which can quantify bradykinesia as well as rigidity, but we're really interested in gait specifically because of its correlation to falling and the risks that poses to the community of people with Parkinson's disease.
So this might be a good spot to insert another question from one of our members, Monique, if I can jump in. Karen asks, could closed loop stimulation help with balance? And selfishly speaking, I would add shuffled gait.
That's a really good question, and it's one that we're very interested in answering. It's difficult for us to say at this point whether it does or doesn't help, but specifically shuffled gait falls under the umbrella of gait impairment and is something that we're very interested in looking at, and that our quantitative metrics for gait impairment is specifically looking at.
Is gait impairment just sort of a wide range of gait issues, whereas freezing of gait is actually when you can't move?
Yes. So freezing of gait is a really large group of symptoms that includes things like shuffling, decreased stride length, decreased arm swing, whereas freezing of gait is more where people get the full freeze as well as the fettination leading up to the freeze.
Great, thank you.
I have a quick question, Monique. Can I jump in?
Yeah.
This goes back a little bit earlier on in the, well, actually, let me ask this question while you're on this particular slide. Somebody mentioned, was it you, Jillian, that there's a requirement or exclusion criteria for Kaiser? Could you explain that again? Kaiser members?
Yeah, so this one is really unfortunate and has caused our lab no small amounts of grief in the past. Because participants need to transfer their care to Stanford, they can't do so with Kaiser insurance because unfortunately Kaiser insurance only covers Kaiser providers, which Stanford is not.
Mm-hmm. Okay. And then I had one other quick question, sort of for my own edification. I want to make sure I understand and our audience understands the difference between open loop and closed loop. So I think what I've gathered so far is that most of today's procedures, DBS procedures and hardware and software focus are of the open loop category. In other words, data is essentially traveling only one direction from chest implant to brain implant and not back again. Whereas in the closed loop model that you're proposing, there is data being generated in the probe or in the, whatever you call the unit that's implanted in the brain, back down to the stimulator. And so that's the closed loop.
Exactly.
Understand that correct?
That's perfect. The open loop essentially is steady state. So it's not going to change unless a clinician changes it or unless a patient changes it on their patient programmer. Whereas you're right, closed loop would adapt and change either to a neural signal coming from the DBS lead or from kinematic signals coming from ankle sensors, for example.
Okay, and you mentioned frequencies. I heard you say 2 frequencies. Was it 60 and 140? Are those the responses that the chest unit might send back to the brain implant unit?
That's oh, go ahead.
Why just 2? Why can't we run a spectrum of 60 or 61 up to 130 or 39?
That's a wonderful question. So the frequency switching algorithm is only one of several algorithms that we use. And the reason why we're interested in 140 hertz and 60 hertz is because 60 hertz specifically has been shown to help ameliorate freezing of gait and gait impairment. And however, it at times can exacerbate tremor. And so in this algorithm specifically, it's adapting between 140 hertz and 60 hertz whenever someone begins a freeze. So as soon as the algorithm senses that someone might freeze, it will switch them to 60. And when they're no longer freezing, it will put them back on 140, with the idea being that the 60 hertz should be able to kind of power them out of a freeze, but they'll be on 140 most of the time so that their tremor isn't being exacerbated. Got
it. That helps. Thank you.
So if someone is coming to the lab and they have the DBS and they're getting this sort of, they come to your lab, I don't know how often they have to come in, but you're making the adjustments while they're in the lab and they're actually feeling the sensations or the effect on their gait in that moment, right? So what happens then when they go home? Are they not feeling that, or is it only when they're in the lab that they're getting that impact?
That's a really incredible question. So at this time in the spring study, we are only doing adaptive gait or adaptive DBS in the lab with the researchers, although we do monitor to make sure that our participants aren't experiencing other symptoms when they're sent home on their normal clinical stimulation.
Oh, okay. But they have the DBS, so they would be experiencing the benefits of DBS for all the other reasons they might be using DBS, like the tremor or the sleep or whatever. They still get the benefits of the DBS 24/7.
Exactly.
They just don't get the benefits of the adaptive piece unless they're in the lab with you.
Yes. So when patients are sent home, participants are sent home, they're on the DBS settings that have been optimized by their clinician. And so they should experience the clinical benefits that they would expect to from any normal clinically optimized DBS system.
In an open
And
model.
which goes back to what you were saying earlier about the care team, right? So you're really getting your clinical care around the DBS at Stanford then. So you really do have to transfer all of your care. Got it.
Not necessarily all of it. So if you have a general neurologist, you can stay with them, but specifically your movement disorders care would have to be transferred to Stanford.
Excellent.
One of our listeners, attendees, Chad, is asking, if things go well, what might the expected timeline be for general availability of closed loop DBS therapy? And if one is an early recipient of this, and if improvements in the feedback process are later identified, is the expectation that an implanted device could be reprogrammed based on the new standards?
Before you answer that, can I interrupt? Because there was an earlier question that said that I understand that Medtronic's Percept stimulator has the closed loop software built in already, but it's not turned on. And so do you know when the FDA will be allowed to turn on? So those are kind of related, but maybe we do that one first.
Definitely. So whoever asked that question is very in the know with the available DBS devices. So the Medtronic Percept does have sensing capacity. And the idea is that whenever adaptive DBS is approved, that all the devices that have already been implanted will have an adaptive feature unlocked on them that everyone's clinician will be able to use. Unfortunately, we aren't psychic, and I am not nearly as close with the FDA as I would like to be. And so it's really difficult to predict when or if adaptive DBS will be approved in the US. It is approved in Japan, which is a fun fact.
So it's an investigational drug advice for the study? Is it considered an investigational device then?
Yes.
So I'm sorry, Todd, do you want to go now back to Chad's questions?
Yeah, sure. I'll repeat, I think, the part that hasn't been answered necessarily yet. If one is an early recipient of, I guess, ADBS, and if improvements in the feedback process are identified, is the expectation that an implant device could be reprogrammed based on the new measures, based on the new data received by the body?
So based on the way that Medtronic has set up their current system, basically what would happen in the event that the FDA is making this therapy available, they say that it's safe and tolerable for everybody, then you would be able to ask your clinician whether it would be right for you to turn on the adaptive therapy. So people that are implanted with the current generation of the Percept PC plus S, so if they have the Sensite lead, then it will be able to do this therapy. So it wouldn't require any extra surgical correction or change of device. It would just be unlocking a currently investigational software on the device. And that would be something that would be opened up to every clinician potentially if the FDA approves it. And then, so it would be a really good discussion to have with your clinician in the event that the FDA does approve this therapy. I think that answers the question.
And another follow-on question that Karen has, and I think others have, is if I had, I don't, but if I had an earlier model DBS that's open loop, non-adaptive, could that, and I guess you'd probably ask me which model I had, but could that be retooled and reprogrammed to be a closed loop process, a closed loop system?
It depends on the leads that you have. So if you have leads with a sensing capacity, then and that were compatible with a current neurostimulator that had a sensing capacity as well, then theoretically, yes. But it is device specific. So that's a harder question to answer.
Okay. Karen was asking about it. Would the chest battery need to be changed in order to make it a closed loop model? So it's more than just the chest unit, it's the leads that are in the brain implanted unit. Got it. Okay.
There's a couple questions about other brands. Are you using the Medtronic then? Is that the device? Yeah. And so a couple people are asking about Boston Scientific. If that unit, is going, are you studying that unit? And, I guess what a follow-up question would be, what if you have that? Can you get it removed and then have the other one put in? Can you change them out? Like, how easy is that to do?
That's a really good and slightly more clinical question. So every device has its pros and cons, and we always encourage patients and potential participants to speak with their providers on what would be best for them given their symptoms.
But at the moment, do you know if the Boston Scientific devices have the ability to be closed loop?
I believe that the Medtronic device, the Percept PC+S, is the only one that has a sensing capacity. Amelia, could you fact check me?
Right, so that's why we work so heavily with Medtronic at this point, is because they're the one that has the technology to do the sensing. And there's definitely certain advantages to different companies and different devices. So it's a really good thing to talk about with your clinician, but our partnership with Medtronic is largely driven by the fact that they worked on getting a sensing lead first. To the best of both of our knowledge, I think they're the only one currently on the market that have that capability to do, at least with a lead that's sensing that kind of deep brain closed loop system. They're the only one that can do it currently.
I have a question.
The question about the battery made me think of something that you said earlier in the talk, and I don't know if I misheard you, but does the open loop system somehow enhance the battery life? Does the sort of like circuits in the brain like charge the battery like an electric car or something?
So it's not necessarily as if it's charging itself. In a closed loop system, the idea is that the intensity of the stimulation is only adapting when you really need it. And so sometimes it can sit at a lower intensity than you would otherwise have on an open loop steady state system. So over time, there's less energy being delivered. And the idea is that this would allow batteries to last longer because the average intensity would be lower in a closed loop versus an open loop system.
Got it. So it's just more efficient. That's great.
Let's see, I have another question here again from Chad, back to that inclusion exclusion slide. I think I saw that one of the inclusion criteria he said was complications of medications such as wearing off effects. Can you explain what the medication wearing off effects typically are?
Yeah, so wearing off effects, by our definition, are when people experience off states while they're on medication. So you feel as though you aren't on medication even when you are, as well as side effects from medication like dystonia and dyskinesia.
Okay.
So Chad's just throwing him out there. Way to go, Chad. Thanks for all the questions. Can you describe the neurobiology of how DBS works? Is it known?
That's a very good question, and there's lots of debate in the field. So I think there's still even bickering about whether it's inhibiting or disinhibiting.
That's one of the fun things about this field, is that there's a lot of room for discovery, meaning that we don't have all of the answers yet. So we don't fully understand the mechanism behind deep brain stimulation therapy. It kind of came from the idea that there used to be therapies where they would completely ablate a part of the brain, and then they were realizing that when they put an electrical signal there, that they could also cause these same benefits of an ablation, which is better because you can turn electricity off and you can't unablate an area of the brain that you ablated. So it kind of came historically from that area, so that they haven't quite figured exactly what's going on in the circuitry yet. but that's a great question.
Also, interestingly, stimulating as opposed to ablating has longer term benefits than the initial kind of honeymoon phase that people experience right after they get DBS, which is caused by like a micro lesion effect.
We have a couple folks pushing a little bit on the balance question we asked a while ago, which is great. Let's get clarity. We asked about if the current sensors can detect more than just freezing of gait, and I asked about shuffle gait, but balance. Why, if balance is such an important component of our walking, can it not be sensed by your sensors and improved upon?
That's a wonderful question. So we do actually have sensors that can test for balance. We have ones that go on people's chest and on their lumbar, which can track where their center of gravity is in space. Mm-hmm. But that isn't what we're adapting on in this study.
Okay. So maybe in the future.
Possibly, yeah.
Safe to say that the brain, that those sensors can pick up other elements like my tremor or any of the other motor symptoms of PD in the future?
I think that's one thing that a lot of researchers are really interested in, and there's different groups primarily focusing on different areas, which is really good because then you get really subject matter experts. But I think that once these therapies are potentially approved, it'll really open up more avenues for research to get those symptom-specific relief or targeting an ADBS algorithm for a symptom-specific, like a tremor or a balance or any of those other symptoms that you may experience as part of your Parkinson's disease diagnosis.
Good, thank you.
So what's the current status of the what is it, spring study? Is it, how many people are you planning to enroll? How many have you enrolled? Like, where are you with the progress of the study?
Yeah, so our NIH milestone that we hope to reach by the end of the study is 14 people to enroll. We currently have 9. So we're doing pretty well. Lots of people are in active data collection.
And how long did it take you to get the 9 people?
We're in year 3 currently.
Year 3.
We just started.
Great. And so if anybody is interested in learning more about it, I think they could email you. Is that what we should do?
Definitely. Email, call, messenger pigeon, probably less so, but yeah.
Okay. And it sounds like, are there any upcoming studies that we might want to be waiting to hear about from you guys? Any interesting things you're up to?
None that we're allowed to talk about yet, but I promise that you'll be the first to hear when we are allowed to talk about them.
Okay, great. Well, and it sounds like everybody can sign up for your listserv to get notified about trials that they might be interested in.
Definitely. And in addition to signing up for the listserv, if this specific study isn't of interest to you, or if you don't feel that you're a candidate, but you are interested in being involved with the Bronte-Stewart lab specifically, feel free to email Emilia or I, because we do have other studies coming up, and we can keep you in our own smaller lab registry so that we can reach out to you directly if there are other opportunities for research.
Great. I'll allow a shout out and a thank you to Donna, who confirms what you were both saying a minute ago. She says, correct, only Medtronic Percept has sensing technology with legacy and new Sensite leads. Sensing gesture is FDA approved, whereas closed loop is not. Thanks, Donna. Is that right, ladies?
Correct.
Summarize that accurately? Good.
Thank you for that fact check. We appreciate it.
It's always a fear to be wrong on recording. I'm seeing one last question that's in all caps and seems a bit urgent. Does this scope include MSA? I'm not sure I know what MSA is. Multiple sclerosis.
Possibly multiple sclerosis. Is that right, William?
William, feel free to unmute yourself and ask the question directly if you'd like.
Same goes for everyone after William. If anybody else has any questions you'd like to lob out yourself, feel free.
Yeah, we're doing great on time, so we can take more questions.
I have a question.
Great. Who's that?
It's Teresa.
Go for it, Teresa.
Okay, I was wondering, with new technology like this, is it typical that initially it's cost prohibitive for most people?
That's a good question. So in our current study, the spring study, at the moment, Medtronic is covering the cost of the device, and people's insurance usually covers the cost of surgery.
Is that primarily if they're involved in the study, or
So
what about after the FDA approves the device? Does the price, allow others to participate in it?
yeah, so our experience is only with people who are participating in the study. It's difficult to say what access to this would look like after FDA approval.
Okay.
There's no cost of participating in the study, though.
No.
Okay.
Okay.
Do participants get compensated for their time?
No. So because DBS clinical trials are difficult ethically, it's not ethical for us to compensate our participants. Although at certain distances, we will compensate for gas or hotel stays if they're staying specifically for research in the area.
And so how many visits are we talking about? I mean, clearly there's the initial surgery to undergo, and then does it go on for how long after that, and how many visits per month or year?
Yeah, that's a wonderful question. So the research team isn't involved with people's clinical care beyond making sure that they get their device. So after surgery, we really have no control over how long it takes for someone to be clinically optimized. And we only begin research visits once they are. So this could take anywhere from 3 months to a year. It just entirely depends on the clinical decision-making process.
Mm-hmm.
But outside of clinical aspects, we tend to see people once every 3 months. And there are 6 research visits in total, each of which consists of 3 to 4 days and can be extended based on participant comfort, because some of our participants have more stamina than others in terms of the length of a research day that they can tolerate.
Got it.
It looks like
I have a question.
Oh, yeah, go ahead.
Anatomically, left from right, are there bilateral thalamic implants for deep brain stimulation?
Yes, so in our study, there are 2 leads, one of which goes in the right subthalamic nucleus and the other which goes in the left.
Is there a regulator from left from right in a rhythmic fashion?
Yeah, so in our neural adaptive algorithm, the lead that's sensing in the right will change stimulation based on what it's sensing, and the lead that's sensing in the right will change stimulation based on what it's sensing locally. So theoretically, both leads could be doing different things in terms of the stimulation that they're delivering.
Can you develop a rhythm with the alternating frequencies?
What do you mean?
To coordinate left from right activation, is there some way to regulate that?
Can you give us an example, Tom? What do you think?
With my Parkinsonism, I tend to have more activity on one side.
Yes.
Yeah, so I think a lot of people with Parkinson's have one side that's more affected than others. If the neurostimulator sensed that one side had higher or greater pathology based on the biosignal, then it would deliver more stimulation to the side that was more affected.
Wow, that's brilliant.
How about recovery time?
Can you give me an example?
Do you have a maximum stimulation that can be done where you get no response?
Are you asking if if there is a stimulation that is so low that people don't respond to it.
It's a regulator of rhythmicity, apart from your side of your implant.
So if the receiver's pick up freezing of gait and the 60 megahertz frequency response isn't effective, then it'll go up to 140, right?
Okay.
So that's one of our algorithms. So that is a frequency switching algorithm, wherein as soon as someone freezes or arrhythmicity is detected, it will switch to 60 to ameliorate freezing, and then can go back to 140 when they're no longer freezing. In other algorithms, it will instead increase intensity whenever someone is freezing or is experiencing gait impairment.
Are you allowed for neurochemical recovery after intense stimulation?
One thing that I think might help to explain. So when we're doing our first day of testing, we have what we call calibration to make sure that we're finding stimulation intensities that are safe and tolerable for you specifically. And that might look different for each person, and on each side of the brain, it could look different. So we're looking for the lowest stimulation intensity where you see a resolution of symptoms. You're not at something that's subclinical. So say, for example, if you were at 50% of your clinical stimulation, you might not experience the same benefits for tremor reduction. So we want to make sure that we're above that threshold so that you're not uncomfortable. And we also don't want to go too high so that you're in a place where you would start experiencing what we call adverse event threshold. So that's where you would have some sensations that are uncomfortable sensations, similar to what you might expect if you had too much electrical activity. So tingling or pulling or any twitching or anything like this. So we're making sure that we're staying within boundaries that are safe for each person and making sure that it's tested and within a level that would be set by a clinician that's safe for you. So we're not going below where you would expect to see a benefit of therapy, and we're not going above a stimulation therapy that would be too intense for you. Does that help a little bit?
It does.
I can't imagine the IRB would approve that either.
No, definitely not. Definitely not.
So that's great. William had put in the chat that MSA is multi-system atrophy. I don't know if he means atrophy. Yeah.
Yeah. I think that would exclude him from our study specifically, although there might be other studies at Stanford that are specifically looking at that comorbidity, which could be really interesting to look into if you're interested in participating in research.
Great, thank you. Are there any other questions? Oh, we have one more that just came in from Ben. How about neurofeedback using biofeedback? I'm not sure I understand the question. Do you guys understand the question? Technology. How about neurofeedback using biofeedback technology?
I'm not sure I understand the question.
Yeah, so let me see if Ben, if you're able to unmute and ask the question, that would be great. So we can get clarification on what you are interested in knowing. Meanwhile, Robin chimes in and says, is festination the same as freezing of gait? And I hope I pronounced that right. Is that right? Festination?
Festination.
Yes.
Okay.
Yeah. So we kind of conceptualize festination, which is the progressive shortening of steps, as something which leads up to and is kind of included in a larger idea of freezing of gait. And is definitely under the larger umbrella of gait impairment.
Okay. Would be included in this study?
Yeah, that would, if you experience festination, that would be enough gait impairment to qualify you for the study based on that inclusion criteria.
Okay.
Thank you, Robin. It looks like William, you're trying to get us a question. I can't unmute William. Monique, maybe you can unmute William.
Oh.
Barrett.
I sent him a request to unmute, but I don't know if it's happening.
While you're attempting that, I do have one more question. This is Teresa.
Go ahead, Teresa.
I was wondering if someone is in the early stages of Parkinson's and has not yet started medication because of various reasons. I remember reading or hearing that a doctor indicated people look to DBS much later than they should. Why? Well, can you comment on that?
So this is a little bit into the clinical territory, which is why we were both hesitating to answer this question. I think there have been some research studies that have been done to look at, currently deep brain stimulation therapy is something that would be looked at a little bit further down the line in Parkinson's disease progression. And there have been some studies to kind of see whether that should still be the case, but I think clinically still it is typically used further in disease progression. And I'm not sure that there's a large movement right now to change that. But it's certainly something that researchers are interested in seeing whether there could be some potential benefit to doing deep brain stimulation earlier. And it would be certainly something to discuss with a clinician to make sure that, your candidacy for something is right for you in that moment of time.
Okay, thank you.
Nicely answered, Amelia. Any other questions?
Hi, this is Rob Lazarus. I had a question.
Hey, Rob, go for it.
So about 3 years ago, prior to COVID, when we were still meeting monthly in person, we had a team from UCSF come to talk about this same topic. And just curious, are you working together with UCSF? Do you coordinate what areas you are focusing on, specifically related to closed loop DBS? Or are you not competitive, but working independently from their team?
Yeah, so a lot of researchers in the field are using a system from Medtronic that's a research device that allows for more capabilities in terms of computing power and things that the device is able to do. And so one really cool thing that we've done in collaboration with a lot of labs across the United States, and I'm not sure potentially the world, that are using this device is we have what's called the Open Mind Consortium. So researchers are sharing lessons that they've learned using the device so that a lot of the stuff isn't repeated in terms of like software and hardware developments, making sure that all of the batteries are regulated properly and correctly. So there is collaboration between research teams and especially people doing this adaptive deep brain stimulation therapy treatments, even across different indications for adaptive deep brain stimulation, because there are other indications such as epilepsy and depression and other types of neurological disorders that are looking at this kind of therapy. So collaboration within the research field has been really helpful there.
Excellent. So we have the question from William was coming back around DBS, around neurofeedback. He's, no, I'm sorry, that was Ben Rivers. I apologize. This was the one on multi-system atrophy. And he's asking, is it true that multi-system atrophy does not work with DBS? I think that's what the question is. Is that?
That's how I read it.
Okay, is that something, I think you guys addressed that a little bit earlier and said that it was not?
It's not with it. Anyone with multi-system atrophy wouldn't qualify for our study. That being said, that diagnosis entirely, because we are researchers and not clinicians, is entirely out of my or Amelia's wheelhouse, unfortunately. So I'm sorry we can't give you a more satisfying answer.
Great. Well, honesty is better.
For sure.
Awesome. Well, unless there's any more questions, I think we'll go ahead and wrap up. This has been absolutely wonderful to host you all, and thank you for spending your Tuesday evening with us. We really greatly appreciate it. Most of us are over here in the East Bay. If you guys ever come up to the East Bay, give it a ring and we'll invite you to one of our in-person meetings. So it'd be great to hear updates from the lab again.
Thank you so much for having us. We really appreciate all of your time and your really thoughtful questions.
Yes, absolutely. And please give our best to Dr. Bronte-Stewart and thank her for allowing you guys to join us. And with that, we'll go ahead and end the evening.
Thank you.
Thank you, Amelia. Thank you, Jillian.
Bye-bye.
Bye-bye.